Thank you all for coming, for those of you who are in the room and those who are also in the Zoom room. Thanks for joining us today. I'm Steve Jaffe. I chair the Department of Medical Ethics and Health Policy. I am not your usual host, Holly Fernandez-Lynch. Holly and I co-lead this and co-organize this program. Holly is away at a meeting, and so I'm stepping in for her to do introductions. Couple of words as usual before we start. We're about midway through the semester of reps talks. Here's the list of talks that we've had so far, a couple so far. Today's talk, and then just upcoming, and I hope you all can come on April 22nd, which is not our usual second Tuesday of the month, but due to Dr. Wilkins' schedule, we just adjusted a bit. Consuelo Wilkins, who's a professor and vice dean at Vanderbilt and Meharry, and probably one of the world's leading experts on inclusion of diverse communities in biomedical research, will be here with us. And a program is jointly sponsored by the Cancer Control Program of the Cancer Center. That should be a really wonderful talk. In May, Allison Bennett, who's an expert on the ethics of animal research, will be coming to talk about that topic. So please come, and please also, for all of your friends and colleagues who are interested in animal research or work in animal research or oversight of animal research or anything like that, please encourage them to come. And then in June, the last for the semester, Angela Bradbury, who's a faculty member in Hematology Oncology Department of Medicine, will be talking, I believe, about the inclusion or conducting research with adolescent populations and genetic research with adolescent populations. As usual, just want to let you know that we have created through the department a series of online educational activities through related to the ethics of human subjects research and other biomedical ethics issues. Here's the topic. The first of these is you're eligible to get credits, sort of an advocacy credits, sort of human subject approval. I may be a biased observer, but it's a vastly better program than the city program, which is quite painful to sit through. I hope there's nobody in the room who has been involved in producing the city program, but ours is better. A word just to thank our sponsors, all of whom are listed here. This is a joint effort of a bunch of different groups at Penn School of Medicine, Penn Medicine, and CHOP, who are all involved in human subjects research. So grateful to all of them for collaborating to make this series possible. With that, let me briefly introduce our speaker, who I suspect is known to many of you in the room. Emily Largent is the Emanuel and Robert Hart Professor of Medical Ethics and Health Policy. She also has a faculty appointment at Penn Law School and is chief of our Division of Medical Ethics. She actually, one of her first degrees was a nursing degree from Penn. She then did a predoctoral fellowship at the NIH in bioethics, which was her entree into the bioethics space. Got her PhD in health policy and her law degree from Harvard. Shortly thereafter that, we were fortunate to recruit her to our faculty in 2017, where she's been ever since. She has grants from the National Institute on Aging for research related to our changing understanding of neurodegenerative diseases, especially Alzheimer's disease. And she really is one of the, if not the leading national experts on the ethical and legal issues facing adults with dementia and other causes of diminished capacity, and on ethical and regulatory aspects of human subjects research and the overlap of those two things, which I think is what she'll be talking on today. So Emily, thank you for doing this, and welcome. I should have noted, Emily invites, if there are like any sort of clearly clarifying questions while the talk is going on, we'll take those. Otherwise, we'll take questions and comments at the end of the talk, and I will moderate the questions that come in over Zoom.
Thank you so much. I'm glad to be here, see a mix of familiar faces and new faces as well, and to be talking about something I think about quite a lot in a variety of contexts, right? The ethical considerations that arise when we conduct research with older adults. And as you'll hear throughout the talk, I thought about this in partly through my role with the Alzheimer's Disease Research Center here at Penn, where I'm part of the Outreach, Recruitment, and Engagement Corps, as well as through various collaborative grants I'm part of, such as the Impact Collaboratory and the Penn AI Tech Collaboratory, which I'll talk a bit more about near the end. So as Steve said, I have grants from the NIA and the Greenwald Foundation, and I've received honoraria from Eli Lilly and Novartis. And my agenda for us today, I think a little bit ambitious, but something we can certainly accomplish, is to describe the older adult population in the United States, as well as notable trends in aging, which I think are quite relevant to the importance of research in this population, as well as to some of the challenges we encounter. To talk about why it's important to include older adults, including vulnerable older adults in research, to really make a positive case for that. To characterize participation barriers they experience, to discuss means of overcoming those barriers. And then because it becomes an issue, one that I encounter so frequently, I wanted to spend some time really talking about key issues related to capacity and consent to research participation. Incapacity is a particular kind of vulnerability that we encounter at higher rates in this population, but one that many investigators I find in particular are not quite ready to grapple with. And then finally, I'll end by just highlighting a few resources for learning more about issues at the intersection of aging and research. So in terms of the key demographic trends to be aware of, right, we know that the United States is an aging population. In 2020, about 1 in 6 people over was aged 65 or over, and that number has been increasing quite a bit with time. And it is projected to continue increasing, right? So the number of Americans is projected to reach, older Americans is projected to reach 82 million by 2050. So and not only that, but we do distinguish between different groups of older adults. And so one thing we see is that there is increasing growth in the oldest old, right? Those who are 85 and over. So hopefully this, at least thus far, we've motivated the idea that this is a growing population and their health needs are quite important for us to address because we are an aging population. Another thing that's happening is that this is becoming a more diverse population over time. So the Kaiser Family Foundation says that by 2060, people of color will comprise close to half of the US population ages 65 and older. And this becomes quite important when we think about issues like health disparities, which we will delve into in a bit. And then there are some notable demographic challenges that we need to be aware of. So gains in life expectancy recently stalled, driven largely, but not entirely by COVID. So we need to be thinking about living longer, healthier lives. Wide economic disparities are found across different population subgroups of older adults. Though the overall poverty rate has dropped, this is a live issue. More older adults are divorced and living alone. You'll see why this is important as we talk about the various constraints that research places on people. And older Americans really do face a caregiving gap, especially those with lower incomes and dementia. And it's unsurprising, right, as we think about an aging population, that we expect that the demand for caregiving is going to increase sharply as the number of older adults grows. Okay, so let's talk about including older adults in research. I'm glad people are here. Hopefully you already think this is an important issue, but it's a question I actually get quite a lot from people, which is why don't we just avoid the various ethical challenges that are associated with working with older adults by simply excluding them from research, right? If we don't have a vulnerable population, then we don't have any ethical challenges, right? It's kind of the magic eraser idea. If we just exclude them, we avoid any sort of ethical challenges. I have 3 key responses to this that I think are quite important to think about. One is that older adults are not necessarily vulnerable. Whether they're vulnerable or not, older adults have as much need for evidence-based care as others. And enrolling vulnerable older adults in research may be ethically required. In fact, excluding them while you think you're avoiding problems, you might actually be creating different ethical challenges or problems for yourself. Let's delve into each of those a bit more. First, this idea that older adults are not necessarily vulnerable. I particularly like Samia Hurst's definition of vulnerability, which is that somebody has an identifiably increased likelihood of incurring additional or greater wrongs. And I like this definition because it encompasses both consent-based accounts of vulnerability, which are quite common, right? That's one reason why we think children are vulnerable, because they can't understand and give consent to their own participation in research. And it also encompasses harm-based accounts of vulnerability. So there are some groups like pregnant women or fetuses that we think might be at greater risk of being harmed in the course of participation in human subjects research. And so that's why we might think of them as vulnerable. And so this definition gives us a little bit broader terms so that we can really think of both. But when we think of this definition, right, just the fact that you are older doesn't necessarily make you vulnerable. Right? Being older by itself does not create vulnerability. Now, that's not to say that there aren't potentially a lot of sources of vulnerability older adults might experience. And I wanted to walk through these in some ways because I think that the issue spotting is an important part of conducting research with older adults, really thinking about your particular study population so that you can tailor protections to them. So obviously, some older adults do have cognitive impairment and so may lack decisional capacity. So those consent-based vulnerabilities. People with cognitive or functional impairment are often dependent on others, for example, to assist them with activities of daily living. And that kind of dependence is itself a source of vulnerability, especially when we think about the voluntariness of participating in research. When somebody is in a position of power over you to meet your daily needs or not meet them, you might feel more obligated to do something when they ask you to do that. This same issue comes up for people who live in long-term care facilities, whether or not they have any sort of cognitive or functional impairment, right? They live in what Goffman might refer to as the total institution, and because they're constrained by others, their participation might similarly be involuntary. Many older adults have comorbidities and polypharmacy, and so could be at greater risk of harm. People living where research is conducted, especially in long-term care facilities, are at greater risk for privacy violations. And I think an example might really highlight this. I was consulting on a study that was interested in looking at an intervention to reduce agitation during bath time, which of course is quite difficult for both staff and residents in long-term care facilities who need help bathing. But they wanted to have researchers go into the bathroom and actually observe the bathing process while the person was nude and being bathed. And that was in part motivated by good scientific reason. They wanted to make sure that there was adherence to the protocol, that people were following and adhering to the intervention. And yet at the same time, they thought that they could just go into the bathroom and they could watch this. One group I'm very interested in are those who are unbefriended. So unbefriended refers to people who don't have decisional capacity. They haven't expressed their wishes previously in any sort of written document, and they lack a person who is an obvious surrogate to speak on their behalf. A closely related term to this is adult orphans. These are people who have capacity but are at risk of becoming unbefriended. And so when we think about them, they're at risk for poor quality care due to the lack of advocacy, right? They just don't have people. So we know, for example, in nursing homes, they tend to have poorer outcomes because people aren't there checking on them. And then people from minoritized groups, understood across a number of dimensions, might have different or additional sources of disadvantage. And so it's really important for older adults to consider intersectionality. So my second argument, right, is that it's perverse just to claim that you're protecting older adults by excluding them from research, right? On the one hand, it might thought to be very protective. I'm not saying it's not well motivated, but we know that adults are underrepresented in research. And as a result, clinicians often propose treatment plans based on data from younger, healthier individuals that really might not generalize to the older adult. There are times where, due to the absence of evidence, clinicians just don't offer interventions to people. So they're missing out on treatments or interventions. Healthcare systems lack evidence to support the widespread adoption of interventions and services targeted at older adults. And as a result, we know that many older adults experience poor quality care that's fragmented and fails to address their needs. And when they're involved, that of their care partners, right? So many people who are affected by this lack of evidence. And then in terms of inclusion of older adults, I think there are times when it is permissible or even required. So when I talk to investigators and I'm doing consultations, I often recommend that they ask themselves whether their valuable research objectives, right? And that's part of ethical research, is you want to be asking a socially valuable question, but whether their valuable research objectives can be met by conducting research in a population that isn't vulnerable. Right. And if the answer is, yeah, you can meet those objectives, then maybe you shouldn't be enrolling vulnerable older adults. But sometimes the answer is going to be no, you can't meet those objectives. So just some obvious examples, right? If you're studying a drug to treat symptoms of cognitive impairment and you want to make sure it works for people with both mild cognitive impairment and dementia, those two populations are meaningfully different in ways that suggest that you need to study the drug in both of them. Similarly, if you're developing an intervention to improve quality of life for people living in long-term care facilities, who I said were vulnerable, right, because of the dependence they have on others, you will need to conduct your research in a long-term care facility, right? It's not meaningful to conduct that research in the community and assume those results will generalize to a long-term care facility. Now, just to underscore, right, you want to enroll vulnerable older adults when their participation is scientifically important, right? It should be motivated by the scientific questions you're asking, not because enrolling them is convenient, right? It might be very easy to go to a long-term care facility because you have what we might refer to unpleasantly, right, as a convenient sample or a captive population, right? People who are very easy to enroll because they're just there already. But we don't want to do that because it's convenient. It should really be motivated by conditions that are relevant to them and because they need to be included. I would say there might also be justice-based reasons to include vulnerable populations. So during the COVID pandemic, for example, given the high risk of morbidity and mortality for older adults who contracted COVID, there was a lot of interest in having them participate in vaccine trials, both so that we could have generalizable data and understand how it affected them, but also because we thought it was important to offer them the benefits of research participation. Now, if vulnerable adults are enrolled, they are entitled to special protections, and the nature of those protections needs to be tailored to the particular reasons why they're at increased likelihood of incurring additional or greater wrongs, going back to that definition from Samia Hurst. So for example, if comorbidities are concerning to you because they unfavorably change the risk-benefit profile of the proposed intervention, you should consider additional protections to minimize risks. For example, perhaps you need more frequent monitoring. And if there are privacy risks in a long-term care setting, I gave that bath example, you might do things like engaging stakeholders to understand privacy norms and consider limiting direct observation. So in that particular study, right, there was interest in an audio recording rather than having somebody who is engaged in direct observation, or in training staff to be able to take and show that they were complying with certain things using checklists rather than having a research assistant or truly like a third party who is unknown to the participant and staff there. So let's talk a bit about barriers to older adults' participation in research. Hopefully at this point, right, you've come along with me. You see this as a growing population. You see that there are reasons why they have unmet needs for evidence-based care. And so we want to go ahead and pursue research for them, thinking that that is ethically important. Now, there are many reasons why older adults are underrepresented in research, and we have to take into account all of these, right? Oftentimes it has to do with very strict inclusion-exclusion criteria for studies that really disadvantage older populations. This could be in the form of strict age cutoffs, which sometimes, but not always, are justified by scientific reasons. Restrictive exclusion criteria, like polypharmacy, it can sometimes be a reason why people are excluded from research. And there can be blanket exclusion of cognitively impaired individuals. And so we can imagine that all of these, right, well, not necessarily age cutoffs, yes, but the others, right, they're not necessarily things that on their face are going to affect older adults, but disproportionately as applied, they do affect older adults. We know they also have reduced mobility and limited or inadequate travel options to various trial sites. It can be quite burdensome to get there. And talking with older adults, I know many of them, and I see some research coordinators I know who have to talk to people to come into Penn, and they say they actually hate driving into Philadelphia. They don't like the traffic. It's hard for them, so they just don't want to do it. They have low digital literacy relative to other populations, although I will say that smartphone, internet, and laptop use have all increased dramatically in recent years, and those have been further accelerated by COVID. So this starts to be a little bit on the edge of a myth about aging, that people don't have digital literacy, but it can still be a challenge, especially when we think about trials that rely on digital tools. Like decentralized tools, you might still need to offer supports. And many older adults, due to the historic exclusion of older adults from research, really perceive that clinical trials are not suitable to them, right? They have this idea that it's just not something that people like them do. Now, among those older adults who do participate in research, right, people who say, raise their hand and say they'll participate, we know that marginalized populations are particularly underrepresented, right? And this can do with various things, including their intersecting identities, including race or ethnicity, socioeconomic status, geographic location, and disability status. So as a result of these intersecting systems of disadvantage, some older adults encounter heightened barriers to research participation. So as an example, older adults from rural areas lack access to routine and specialty care. We know that it takes them longer to get appointments and visits, to be diagnosed with things, but this also means they just have fewer touch points with research. It's harder for them to learn about studies and then to be recruited to participate in those studies. So rural older adults often underrepresented. Black older adults experience relatively higher burden of comorbid conditions. For example, much higher rates of cardiovascular disease, which we now understand is not related to race, but racism and social determinants of health. And this disproportionate burden of comorbid conditions leads to their disproportionate exclusion from trials, right? So we know that they are more likely to be excluded because they don't meet the inclusion criteria for a study. And just to underscore, right, the lack of representation can be really extreme. I'm not talking about we're a little bit off. I'm talking about being hugely off. So this is an article that came out in 2021 in the wake of the aducanumab controversy. So aducanumab was the first monoclonal antibody targeted against amyloid plaques, which are a hallmark of Alzheimer's disease, to be FDA approved. And in the study, right, only 0.6%, that is 19 individuals identified as Black, 3% as Hispanic, 0.03%, one person as American Indian or Alaskan Native, and 0.03% as Native Hawaiian or Pacific Islander, right? So when the drug manufacturer Biogen was reporting out the study results, they reported that only 6 Black people were randomized to the treatment dose that was approved by the FDA. 6. I don't even, 2 hands I need, but not all 2 hands, not all 10 fingers. And people were really frustrated at the time that some groups were advancing health equity claims about the importance of approval and insurance coverage so that people would have access to this, really highlighting the disproportionate burden of Alzheimer's disease and dementia borne by Black and Hispanic communities. But there were researchers and others who felt like this was pretty disingenuous because they were advancing claims for approval and coverage, which perhaps benefited the manufacturers, but they really hadn't been there advocating for inclusion in the clinical trials themselves, which would have been where we could have gotten good evidence that was generalizable and perhaps supported these individuals. Now, another question that often comes up is whether or not underrepresented groups are just less motivated to participate or lack trust to participate in research. So one of the areas where I spend a lot of time is secondary prevention trials for Alzheimer's disease. So secondary prevention trials seek to find older adults who are at increased risk for developing cognitive impairment caused by Alzheimer's disease, but don't yet have measurable signs or symptoms of cognitive impairment. And the hope is that we can find a drug or other intervention that really prevents the onset of Alzheimer's disease or slows the progression of symptoms. And so what we know is that these studies tend to be overwhelmingly populated by wealthy, white, educated, and worried well individuals, right? So not representative of the US population, not representative of the population that ultimately goes on to develop Alzheimer's disease. So when I think about participation in trials, I think about it as a bit of a recruitment funnel, right? So I apologize, the text is small on the screen, but we have at the top the general population of older adults, people who might be eligible to participate in our study. And it starts to narrow at each step, right? First, then we have to find the people who intend to participate in a secondary prevention trial, who's even willing to raise their hand and say they'll participate in research. Then we have to find people who are willing to participate and to ask a study partner. Now, asking a study partner is a somewhat unique feature of Alzheimer's disease research, where individuals were required to find somebody who participates with them. That person acts both as an emotional support for them and a logistical support person, but importantly, they provide information about cognition and function that actually helps researchers measure various outcomes. And so you have to find somebody who is willing and able to participate with you. So some research has suggested that there's just a lower willingness even to ask people to be your study partner, right? You feel like your brain health is private. Alzheimer's disease is very stigmatized. You're not interested in even asking anybody, or you don't want to inconvenience somebody. So we get the people who are willing to ask and willing to participate. Then the study partner has to agree with them. Yes, we'll do that. And we know that that's not always the case, that he'll have agreement. And then finally, at the very end, you get the people who have a study partner and who also meet the other enrollment criteria. And a large question for the field has really been, where are we losing people, right? Where are the leaky parts of the funnel? And at what steps are we losing them so that we can hopefully intervene and try to come up with a population that isn't wealthy, white, well-educated, and worried about Alzheimer's disease. So with the team, includes Jason Harlowich, Josh Grill, and Amy Blakely, we conducted a national survey of US adults who were age 65 and over, and we oversampled Black individuals because we wanted to understand them in particular, given the arguments that have been made about their willingness to participate in research. And we asked them in this survey about their intention to enroll in a hypothetical secondary prevention trial, the Healthy Mind Study, right? So we gave them a vignette that described a study that was very much based off of actual secondary prevention trials that are in the field, right? That you would have to go in for infusions, there would be occasional cognitive tests and MRIs, and that your study partner would learn a bit about your brain health. And then we asked them, amongst other questions, about their intention to enroll on a scale of 1 to 5, from very unlikely to very likely. Now, respondents who answered that they were somewhat or very likely were considered likely to enroll. And we went on to ask those people who were likely to enroll about their intention to ask someone to serve as their study partner. So we also measured that. And this was in particular because it's been suggested that the study partner requirement disadvantages Black older adults due to non-traditional family structures, so lower rates of marriage, relying more on adult children who have a harder time taking time off of work and going and participating in trials. So what we found in our full sample of 603 people was that intention to enroll in the Healthy Mind Study overall was quite low. This is not surprising, right? Among those who intended to enroll, which was only 24% of the people we surveyed, the mean intention, okay, so 24%. And I will say that this is a good number, I thought, because it's pretty consistent with what we see in actual other studies in the field, that's about the level of willingness, maybe a little on the high side, but not much higher than we see typically about intention to enroll in studies. Amongst those intending to enroll, we saw some fall off, right? We saw that only 61% of people, or 103, who said that they would be willing to participate, said that they were also willing to ask a study partner. So certainly asking a study partner is a barrier for some people, and they will drop out of the funnel at that point. And the other thing we saw is that people who were willing to ask identified on average 2.14 people that they would be willing to ask. And this is really important, I think, when we think about this area of research, because if you need a study partner to participate, that is in fact an inclusion criteria for these studies. If your bench is really shallow and you ask the first person and they say no, and then you ask the next person and they say no, and you're not willing to ask anybody else, now you can't participate in a study. And we know recruitment is really challenging. And so it's important to think about the issues that it raises when people are not willing to ask more people. Essentially, there were no significant differences between Black and white respondents in intention to enroll or intention to ask a study partner. So this was a surprising finding based at least on what we think of as anecdotal evidence in the field about both low willingness to participate rooted in mistrust of the system, and also this idea that asking a study partner somehow created a bigger barrier for Black older adults. So what we did see as we went through all of this, and we kind of at each step did our statistical analyses, is that what comes out at the far end of the funnel is a study sample that's not representative, right? The people who are willing to participate, the people who are willing to ask a study partner, they do have higher income, they are more educated, and they are more worried about Alzheimer's disease. Those are all quite predictive of people who will make it to the end of the funnel. But I think the best explanation that we have for why we see in real studies very few Black older adults is likely due to structural barriers, right? It has to do with the fact that they're not being asked to participate in research. It has to do with the fact that once they get there, those restrictive eligibility criteria often exclude them from participating. Things like cardiovascular disease, because of the way it can affect brain health, right? Quite important oftentimes as an exclusion criteria in these studies. And so I'm far from the first person to call for the fact that we really do need to be examining whether or not these strict criteria are quite necessary. And if there are ways that we can perhaps help with the study partner requirement by doing things like allowing visits on nights and weekends to make sure that that study partner says yes. And I'm not the only person to have done similar work. So this is a study that was conducted by Winston Chong and others, right? And this was focused on dementia caregivers. So the secondary prevention trial I talked about was people who are cognitively unimpaired, but at increased risk. This was people who already had dementia. And their conclusion was that Hispanic and non-Black dementia caregivers were not less likely than non-Hispanic white dementia caregivers to participate in a hypothetical dementia clinical trial, right? And like us, they say, our study suggests that failures to recruit diverse populations in dementia clinical research are not attributable to less willingness among members of underrepresented groups, but instead reflect structural barriers and historic exclusion from trial participation. So in terms of health disparities, right, we need to be thinking more broadly about ways that we can overcome those disparities that are based on structural barriers rather than simply attributing it to mistrust or unwillingness to participate. So overcoming barriers to older adults' participation. Okay, so why do we need to have diverse clinical trial participation? Here I would highlight an article by Penn colleagues, Aaron Schwartz, Scott Halpern, and others, right? And they talk about three goals that we might have for diverse participation. First, we want to build trust in medical and research institutions by making sure that we are bringing people in. promoting fairness for potential participants in their communities, and also generating biomedical knowledge that's generalizable to all individuals. So overcoming barriers for older adults is going to require multiple context-specific approaches, and I'm going to outline some here for which there is an evidence base. So sponsors and funders, I think, should require inclusion of older adults in, say, drug approval studies, especially for conditions that disproportionately affect them. Investigators should carefully consider trial eligibility criteria and the risk of differential exclusion, right? Some things on their face seem like they're going to be neutral, but then as they're applied, we see that they systematically disadvantage certain populations. If older adults are subject to any sort of blanket exclusions, IRBs, I think, have a role in asking for a justification or suggesting alterations to make sure that there is a scientific reason for this, and it's not just for the convenience and analysis, or because somebody has misperceptions, say, about the vulnerability of older adults and the idea that protecting them through exclusion is the right way to go. I think investigators should consider decentralized trials, including use of telemedicine, mobile health units, and also establishing trial sites that are closer to older populations. We could get to rural older adults this way, for example. I think funders and sponsors can help support these efforts. Part of supporting these efforts is paying for technologies for people who don't already have access to them, like tablets and smartphones, and training research staff so that they're able to help the older adult use that technology. And then investigators should be building trust through various community partnerships to try to bring older adults in and dispel notions that research isn't for them. Another thing that's been of interest is using targeted messaging to improve representation, right? Can we actually advertise trials in a way that helps bring in a more representative population? So here I would point people to the reasoned action approach, which is, has it's theory or a model that has a key belief that there are differences between those who do and do not intend to perform a target behavior along various dimensions. So it's based on attitudes, how they feel about performing the behavior, injunctive norms, that is what they think other people like them do, descriptive what other people think, descriptive norms, perceptions of what other people do, self-efficacy. So do they think that they have the capacity to perform the behavior if they wanted to do it? And then autonomy, do they feel like they can control the behavior? And ultimately, the idea is that if you understand which of these things differ between those who do and don't intend to perform an action, that you can tailor messaging to change intention and ultimately behavior, right? If I change your intention to participate in research, hopefully that translates into participating in the research or enrolling. So in that survey that I described previously that we did with older adults about the secondary prevention trial, we explored the potential for targeted messaging, right? So we asked people a variety of questions about their attitudes, right? If I participated in this research, it would help me help my community. It would help me learn about my brain health. It would give me access to promising new drugs. We asked them if they thought people like them would participate, if people they cared about would approve of them or think it was a positive or a good thing if they participated. If they felt like they could overcome certain barriers to participation, right? I could participate even if I had to drive to a trial site. I could participate even if I had to give genetic information. And doing all of this, what we found is that across the full sample, so this includes all of the people we surveyed, intention to enroll was significantly driven by attitudes. So what they thought would come out of that participation, as well as by both descriptive and injunctive norms and capacity, right? But autonomy really did fall out as something that drove intention. So in some ways, the positive message that comes out of this is that because some beliefs protect intention to enroll and they overlap across all the groups that we're interested in, then we think that universal messages really might sometimes be effective, right? We could appeal to people using messages that draw on attitudinal beliefs like, if you participate, you can track your brain health. That matters to people right across different demographic groups. You can access novel therapies, or you could help others. And those messages might really be successful in promoting trial participation. But when we dove a little deeper into the data, there were statistically significant differences between Black and white survey respondents in the relationship between attitudes and intention and descriptive norms and intention. And so I think this suggests that developing tailored evidence-based outreach messages really could boost enrollment of Black older adults and is something that we should pursue. Now, I've been part of another project that's led by Amy Blakely and Jessica Langbaum, among others, right, that has been working on developing theory-based messages, again, using the reasoned action approach to recruit underrepresented racial and ethnic groups into research registries, right? So these research registries are places where people give their name. They say they would be willing to be contacted about research opportunities in the future. And the hope is that this helps reduce some of the friction in the recruitment process, because once you have a list of people who are potentially interested, you can find them more easily when you have a study that might be a good match for them. And so what happened in this study is we asked people, we found out, first of all, that people just don't even understand the idea of a research registry. We ended up using different language around lists. But we also found, right, that across almost all racial and ethnic and sex groups, attitudes were an important determinant of attention, and norms and capacity were secondary determinants for Black and Hispanic adults, respectively. So again, there's this chance that we might have universal messages, which would be great, but there might also be ways to have targeted messages. And there have been subsequent and ongoing research in working to find out what those messages are that might work, as well as to figure out like what visual images will be appealing. So we've had some interesting findings, like Black older adults were shown different picture combinations, and it turns out they really didn't like the pictures that were all just Black older adults. They preferred more mixed groups, right? So that they didn't feel like they were being targeted. Specifically, right, it risked eliciting certain feelings they had. They wanted to know it was a broader study. But those results are forthcoming. Another way that people have tried to overcome some of these barriers and really address health disparities is to use algorithms to identify potential participants in Alzheimer's disease research. So we know that there are disparities in diagnosis and treatment. Black and Hispanic older adults tend to receive diagnoses, either they're delayed diagnoses, right? They find out later in the course of disease, or the diagnoses are missed altogether. And so if you're interested in finding people with dementia to participate in your research, it's really not as simple as going into an electronic medical record and generating a list of potential participants using either diagnostic or billing codes, right? Because we know, given these disparities in who's diagnosed, you'll miss a whole swath of people who are affected and yet don't have a diagnosis. So this has led to a lot of interest in algorithms or digital phenotyping, where you might identify more people who are living with dementia by using routinely collected data or findings consistent with or associated with dementia, but not as specific as a dementia diagnosis. So this could include dementia-related symptoms or common comorbidities of dementia, such as delirium, frailty, or functional dependence, right? So you can search for these sorts of things and come up with a list of people that you think are likely to have dementia that you might then target for research participation. And in an article that I was part of, right, we think that this is really well motivated, right? Addressing health disparities is good, increasing the number of research participants is good, because we know that these are huge barriers to trial success. They delay it, they cost a lot of money, but there are a number of ethical issues related to these algorithms, right? So generating new sensitive information is by itself a challenge, right? Dementia is highly stigmatized. We know that people experience stigma themselves. They internalize that in some cases, and there's spillover stigma to their caregivers. So saying that somebody is likely to have dementia actually is quite sensitive medical information. And it wasn't in their chart before. There's really a lack of consent for the creation of this information, especially for research purposes. People are not necessarily coming in and thinking that when they're having their blood pressure checked or they're being told that they're frail, that they might also be getting some sort of, quiet assessment for dementia in the background of their medical record. Of course, there's the difficulty that's quite common in these sort of large language models and AI generally, is that there are biases in these data sets that could perpetuate disparities. So when we think about who has contact with the healthcare system, who's being diagnosed, who gets better follow-up care, we know that that tends to be white older adults more so than other populations. And so we can see that we might actually perpetuate rather than addressing disparities. There's a risk of incorrect identification. So we're especially worried about false positives, again, given that stigma. And then there's a question of disclosure. So say you generate a list, even if we think the list is really good about people that we think are likely to have dementia, what do you do as a researcher? Because what we know is that even people who are diagnosed in their charts with dementia don't always know, they are not always told that they have dementia. And that can be for a host of reasons, including lack of provider comfort with disclosing that information, right? But it's the problem of the cold call. You don't want to just reach out to somebody and say, hey, we found you might be somebody who would be really good to participate in our dementia study, given that you might be disclosing for the first time that they even have dementia. So I think that there's a lot to still be worked out here. So I'm going to spend just a few minutes now talking about consent because this really is a common stumbling block. And I'm going to say it's a common stumbling block for investigators. It often comes up in my consultations with investigators. And even though these investigators are very well intentioned, they typically haven't thought in adequate depth about how they're going to handle informed consent for their studies. Now, I will say that consent is an umbrella under which there are a lot of ethical questions that have to be unpacked, especially for older adults, right? So we all know the purpose of the consent process is to allow individuals who have capacity to make a voluntary, informed decision about research participation. And so the questions you need to ask are things like, does the older adult have capacity in the first place to consent to participation? If yes, how can you make sure their consent is informed and voluntary? If no, who can give permission on their behalf? What standard should that surrogate use? How can the older adult still be involved, if at all? And then you have to ask about adults with marginal capacity and also care partners. So I think it's a true thing that researchers working with older adults need a plan to assess capacity, even if, and this is a pitfall I often see, you plan to exclude older adults who lack capacity, because if you can't figure out who lacks capacity, it's going to be very hard to exclude them. Now, capacity is task and context specific, right? You need to say capacity to what, and we think that the threshold differs depending on risk. So that would be study dependent. Cognition is related to, but not the same thing as capacity, right? Cognition affects the decisional abilities that comprise capacity, right? Our ability to understand and reason and communicate choice. But as a result of this, because those things are not synonyms, a diagnosis of cognitive impairment, whether it's mild cognitive impairment or dementia, or a diagnosis associated with cognitive impairment like Alzheimer's disease, does not necessarily mean that somebody lacks capacity. We can't use that as determinative. It's additionally true that scores on cognitive tests typically can't substitute for capacity assessment, which is a pitfall I see people fall into often. You typically can't rely on others' determinations of capacity, so you don't want to ask staff in the long-term care facility, for example, which of your residents does or doesn't have capacity. And I can point out that there are tools that might test capacity for you, such as the MacArthur Competence Assessment Tool for clinical research, or you can use conversation-based approaches. So older adults with capacity are empowered decision makers. If they have capacity to consent to research, then the consent process is pretty familiar, but I think that it can still be enhanced to improve understanding. And these are modifications that I think help everybody participating in research, but can be especially useful for older adults. So consent forms and informational materials should be simplified, right, to the right reading levels. Research staff should be trained to communicate effectively with individuals who say have hearing loss or vision impairment. You need to really allow sufficient time for the consent process to unfold, and you need to allow a family member or friend to be present. We often find that older adults make these decisions to participate collaboratively. And then to ensure voluntariness, especially for people who live in a long-term care facility, it's really important to have a neutral party rather than, say, a staff member reach out to them about participation in research to make sure that they don't either experience or perceive that there are adverse consequences from declining participation. Now, when we think about older adults who have impaired capacity, you're going to need to find a surrogate decision maker for them. Pennsylvania law does not set up a surrogate hierarchy in the research setting, so you need to look for various people who could be involved, whether it's a guardian, a healthcare agent that was previously appointed by the older adult, or a healthcare representative. And Pennsylvania case law recognizes substituted judgment, which really aims at this idea that you're going to approximate the decision the older adult would have made if they were able. Now, there's not great evidence that people are very good at doing this kind of substituted judgment. It's very difficult in research context, right? Because we often haven't talked about things like research participation with friends and family members. It might be difficult to reason from analogous situations. And a population I want to highlight here are those unbefriended older adults, right? Those are people who lack a surrogate decision maker or people who can speak to their interests. It makes them a very hard population to involve in research, despite their really overwhelming needs for evidence-based care. Researchers also need to find ways of involving the person with diminished capacity in that research-related decision-making, if at all possible. So the approaches that we could use for this would be assent, right? And you do need some level of understanding there because the goal is to make sure that you provide information and that the individual wants to participate in research. But typically, assent by itself is not sufficient to authorize participation in research. By contrast, dissent requires no understanding at all. It can be verbal or nonverbal, and it's an objection to participate in research, and that often is treated as determinative, right, if somebody clearly doesn't want to participate. I will say in this space that it can be quite difficult to know if a behavior is dissent to research or a symptom of something else like agitation. Those two can be conflated with each other. So the general feeling is if a person who can give assent doesn't, or if dissent is sustained, or if the response is ambiguous, then the person generally should not be included in research. Now, there is also a group of older adults who has marginal capacity, right? So we know that capacity is not binary, even though we often treat it as people having or lacking capacity, but it occurs along a spectrum. And that's because those decisional abilities that make up capacity are in fact themselves continuous variables rather than binary variables. And so some people do have marginal capacity, right? They're kind of in this blurry area where they're kind of not great, but they don't clearly have or lack capacity. So this is often an overlooked category, I would say clinically and in research, but it's a really important point for intervention. And my research, much of it focuses on supported decision-making, which is a process by which an adult who has marginal capacity identifies a trusted other person who helps them make their own decision. So unlike a surrogate who makes a decision for that older adult, the older adult still is deciding, but they have help from somebody else. Now, empirical evidence that I'm still in the process of collecting suggests that many cognitively impaired older adults and their care partners naturally adopt something like supported decision-making. So I think there will be a lot of receptivity to this model, but it's still really being adapted for older adults. Care partners might also be research participants. So especially in Alzheimer's disease, I mentioned this study partner requirement that you need to enroll with somebody who provides information about cognition and function. Investigators may also need to assess the care partner's capacity, the study partner's capacity. There have certainly been times where people show up and it becomes clear that that study partner doesn't have decisional capacity. And evidence suggests that care partner participant dyads make the decision to participate collaboratively, with the care partner taking on an increasingly large role as cognition deteriorates, right? So we can think about that group there. And then just as an aside, some studies target interventions at care partners with the hope of improving outcomes for either the care partner and or the older adult. Care partners are rarely clearly identified in the medical record, which I think is a real challenge, that we don't have that kind of thing documented in a clear, consistent place. And even if they are reaching out to them, can actually implicate HIPAA. So these are challenges for investigators who are looking to do care partner research.
Can I ask a clarifying question about
Yeah.
that? You say implicate HIPAA, I mean that like it might be disclosing something about the person with dementia that shouldn't be disclosed maybe to the care partner?
Yeah. Yeah, it might be a privacy violation depending on how you're doing it. So additional resources. So what I've done is just really skimmed the surface of issues that arise in research with older adults, right? And so there are a lot of things that occur at this intersection of research ethics and aging. So researchers might encounter, for example, a need to address cases of suspected elder abuse, neglect, or exploitation. Age-based stereotypes can adversely impact research design or even activate stereotype threat in participants, right? Knowing that people expect them to do more poorly, they might in fact do more poorly, affecting your outcomes measurement. There's a lot of interest in these studies in disclosing gene and biomarker results, which certainly come with a whole thicket of ethical issues, such as affecting life, long-term care, or disability insurance eligibility. Older adults' values often differ from those of others, such as the values of their adult children. In studies, they found, for example, that adult children are often quite enthusiastic about surveillance technology meant to keep the older adults safe, but older adults are much more likely to prioritize their independence and not want that intrusion on their privacy. And there are also a lot of issues related to, I talked about recruitment, but retention is an issue in studies, right? Death is expected and can't be avoided, but there are also other populations we know are at increased likelihood of dropping out. So that can be people who are at increased age, who are cognitively impaired, frail, or in worse health. And so there are really ethical considerations around making sure that you find ways to address that, such as, say, oversampling. So I want to leave you with some additional resources, having said all of that. So first, I'll point you to the NIA Impact Collaboratory website. So the Impact Collaboratory has really focused on building infrastructure to conduct pragmatic trials where you integrate research into care, focused on older adults and their care partners. And the Impact Collaboratory offers a video learning library with information on a variety of topics, such as the design and conduct of these pragmatic trials with people living with dementia, waivers of informed consent, which are quite important in pragmatic trials, and also health equity practices. Links to relevant publications, including a publication on assessing and addressing vulnerability in the long-term care setting, recordings of grand rounds and podcasts, and also reports from the Impact Lived Experience panel. So part of the goal of Impact was really to include people living with dementia and their care partners in formulating research questions, identifying important outcomes to be measured, And so they impaneled a group of people who have dementia, care partners, and then people who were care partners who were asked to try to embody the values of the person they cared for living with dementia, who have spoken on topics like waivers of informed consent. And then I would also point you to the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, or Penn AI Tech. This is another collaboratory that's really been had the goal of trying to fund technologies that promote both healthy aging and help adults who have Alzheimer's disease and related dementias. And so there's been a lot of partnerships with both industry and academia happening under that umbrella. But the Penn AI Tech website offers a video learning library with information on topics like generative AI and aging, AI and machine learning for Alzheimer's disease and related dementia, and ethical considerations for wearable devices and AI applications. Links to various publications. I'll point out that the Penn AI Tech Laboratory actually has an ethics and policy core that's comprised of Jason Karlowish and Anna Wexler, colleagues in here at Penn. And we've written about various things like wearable devices, considerations across the lifespan, focusing on things like older adults, as well as digital biomarkers and how those can be used to measure cognitive impairment, which is related to this idea of phenotyping that we talked about earlier. And then there are also recordings of grand rounds. So I think all of these are very rich resources if any of these are topics of particular interest to you or spark your interest. And so in conclusion, right, we know that older adults are a growing and diversifying population, that it's incredibly important to include them in research because of their unmet health needs and the need to gather a greater evidence base. They will face barriers to participation and in some cases merit special protections, but I think we have an ethical obligation to do so. And I'm really glad that you all joined, and I look forward to questions. Thank you.
This is just a basic question. Do you know if older adults have a significantly different like risk tolerance versus younger people? And if so, how does that affect the way they think about research?
So I think it can vary. What we have seen in some cases around, say, drug trials is that people facing dementia, for example, are quite willing to take on pretty extreme risks to avoid certain outcomes. And so it doesn't always go in the way we might think, which is more risk averse. But I think it can be somewhat study specific. Yeah. Care partners too have expressed often a lot of willingness to take on risk on behalf of somebody else if they think they might be able to slow or prevent the onset of cognitive impairment.
In the online, Claire Sherrill raised her hand. So Claire, if you could unmute yourself and ask your question. She heard you.
Thank you. Sorry, it didn't let me unmute. You talked a lot about like sometimes the issues of the surrogate decision maker and accurately representing the older adult's wishes. I was wondering your opinion on the use of advanced directives for participants to provide consent, particularly in the cases where they may be losing capacity, as in the case with dementia or Alzheimer's disease.
Yeah, it's a great question. So there have been, I would say it's actually been a few decades now, there was a lot of interest for a while in research advanced directives where older adults could actually spell out in advance what their interest would be in participating in research. Much like with typical advanced directives that cover healthcare, it turns out there's very low uptake, and you can't always guarantee that people will go on to develop the conditions that they might have anticipated in that research advanced directive. So it is something people have thought about. There were challenges with uptake, but I do think that, especially around things like, people who we already know are at increased risk for Alzheimer's disease or dementia, that communication and recording of interests around research participation would be incredibly useful to do. So I think that, prompting those conversations would be great.
I'll ask a question.
Yep.
As you know, I'm interested in pediatric research, and there's a sort of a widely accepted, though not completely uncontroversial view that wherever possible, you should start in adults who have decision-making capacity, unless there's a compelling scientific reason to start with kids. And only once you've sort of got data from adults, you should move into kids who lack decision-making capacity, at least legally. Is there either sort of in the literature or on your own view, is there a similar sense, or do people think differently about adults with diminished capacity? In other words, start with adults with with capacity unless and until you have a compelling scientific reason to move into populations who lack capacity?
Yeah, so I think there definitely is an interest in asking yourself if you can conduct these research with less vulnerable populations in particular, right, with capacity being one aspect of vulnerability. I think that oftentimes that is the case, that you start in those groups and then you sort of spread things out as you have more and more evidence of safety and efficacy. But there are, just some groups for which we can't do that. It's not possible to do the research without including people. Like if you want to study the advanced stages of dementia, you have to study people who have advanced dementia. So yes, I think that is sort of the default. It's certainly my preference, and yet it's not entirely avoidable that we would do that.
I have another question. Is there I mean, you said cognitive impairment and capacity are not synonymous, of course, we know that, but is there a point at which cognitive impairment becomes incapacitated, like just absolutely? And how do you how do the researchers determine that point?
Yeah, so I had a little hedging language on that slide that, things like the MoCA or the MMSE are not generally good measures, but at some extreme points, there are cutoffs where we realize that it's just so far that at that point it does become determinative. But people are, I think, far too quick to just say that the score is, determinative. And I think that we have to be a little bit more careful, especially in developing protocols for capacity assessment, to say, like, what is our cutoff? Like, what is the MMSE score that we need to have before we say that somebody just can't do it? Yeah. Yeah, Cassie.
So I think as someone without any background in Alzheimer's research, can you just say a little bit more about like what kinds of studies these are? Like, is it the efficacy of a particular treatment, or is it like, and I'm just wondering about the benefit to the participants, like what do they sort of stand to benefit? Is it largely clinical trials on new drugs, or is this a sort of broader set of research?
Yeah, so it's a whole range of interventions that I could point to. So some of them are very much drug trials, right? In the Alzheimer's space, where I've spent a fair amount of time, much of it is trying to find disease-modifying therapies that will slow the onset of cognitive impairment or slow the progression of cognitive impairment. And so there, right, we're looking at the very traditional clinical trial where you come in and you have regular infusions and, you have your MRIs and other things to measure your outcomes, cognitive testing. But there's also in this space a huge interest in behavioral interventions. So I've certainly consulted on studies that are things like music and movement. If we have classes where we play music from when somebody was younger, or if we do interventions like the bathing intervention, right? And I might have had some issues with specifics, but as things become evolved, right, agitation at bath time is actually very common, and it's a good, so people are looking for ways to try to make bathing more pleasant. So those sorts of behavioral interventions also come up. So it really is quite the broad spectrum of things, from social behavioral research, basic science research in some cases, clinical trials. Yeah, it's a range.
And you would think, or I would imagine then, that the standards for how much capacity you have kind of have something to do with the risk that you're evaluating.
Absolutely. Yeah, we think that threshold moves depending on the risks. Yeah. Manon?
I was really interested in this idea of the unbefriended adults, older adults, or people, like you said, sometimes are referred to as adult orphans, people who lack a surrogate. And I was curious if you could talk more about what happens with those unbefriended adults, and how, first of all, like, I guess how they would come to be included in research, but then also something that I'm thinking about a little bit more broadly with regard to Alzheimer's research is like the kinds of things that we're maybe asking of people going through something really hard, and the kind of like what we owe those people by virtue of asking them to do, participate in research, and especially with people who maybe don't have a surrogate or an advocate. Like, are there other kinds of, like, what is that relationship like, I guess? And are there, do we owe something to those participants? We owe something to all participants, but maybe something more.
Yeah.
That makes sense.
So I think it's a population about which we desperately need evidence, and there are, people who are very much working to try to study and identify people, both to see who's at increased risk and also to help assess their outcomes. When we think about the surrogate decision-making, one possibility is to try to find somebody like a friend or a neighbor who might know. So there's often an effort to try to find somebody who at least has some tangential knowledge of that individual and bring them into decision-making. The American Geriatric Society and others have really made it a priority to try to figure out how to provide clinical care for those individuals. I think research becomes somewhat more complicated, but it is a real tension knowing that this is a group that desperately needs interventions. Is particularly vulnerable because they don't have advocates, and also consent becomes so much more difficult for their involvement.
Great, folks, we're right at 1, so please join me in thanking Dr. Baldwin for our time.